This topic is hyperbilirubinemia. So let's break down hyperbilirubinemia. Hyper means high, bilirubin, and then emia means within the blood. So this just means that there's a high amount of bilirubin within the blood. But what exactly is bilirubin? Bilirubin is a byproduct whenever red blood cells are destroyed or broken down. This typically occurs within the liver. The bilirubin will travel through the bloodstream and into the liver. Once it hits the liver, it will then be conjugated or metabolized into a more soluble product that we can excrete through the stool. Babies, whenever they're born, have a higher amount of red blood cells. Their fetal red blood cell count is very high. And so that means that they're turning over blood cells quickly and therefore destroying or going through hemolysis at a higher rate. They have very immature or underdeveloped livers at this point, so it's pretty normal for a baby to be born with jaundice because their liver is not able to process and break down all of the bilirubin effectively. Whenever the bilirubin levels start to build up, this can cause jaundice or that yellow discoloration of the skin, as you can see in this image to the right. Now for a newborn, this jaundice can typically go away or resolve within 2 weeks. But if the bilirubin continues to build up to more excessive levels, this can be toxic and start to damage the neurons within the brain. If untreated, this can lead to permanent brain damage. So there are a few different types of jaundice and even causes for jaundice. Let's start with the first one, known as physiological jaundice or developmental. This is that neonatal jaundice we talked about, which can be normal for most newborns just because their liver is not fully developed and effective to break down this bilirubin quickly. We'll see this onset or presentation after the first 24 hours from birth. Again, this is due to that combination of impaired hepatic function and that increased amount of red blood cells being broken down. Now in premature infants, their liver is even less developed, so we can see an even more prolonged presentation, so this can happen 2 or 3 days after birth. Pathological jaundice, this occurs due to an underlying medical condition or an underlying cause for these red blood cells to be breaking down at such a high rate. This is more immediate onset, and we'll see this within the first day or first 24 hours of life. A few causes of pathological jaundice can be blood antigen incompatibility, which leads to increased hemolysis, and we'll discuss this in more detail in the following slide. Polycythemia, that's just where we have an increased amount of red blood cells and therefore an increased amount of hemolysis or red blood cell breakdown. And even excessive bruising, specifically large bruises or even a cephalohematoma, these can occur during delivery when the baby is being born. A bruise just occurs whenever blood leaks out of a blood vessel and therefore breaks down. And this will, of course, lead into a higher bilirubin level. Breastfeeding can also cause jaundice. We typically see this as the most prolonged onset around 3 to 4 days of life. This occurs due to decreased oral intake, whether the baby's just trying to figure out how to eat the first few days of life, or if the mother is having a decreased milk supply. Remember, we excrete bilirubin through the stool, so if we're having decreased oral intake, that means decreased stooling, and therefore a higher bilirubin count. Now let's discuss this blood antigen incompatibility. Remember, this is one of the causes of pathological jaundice. So you can refer to this image as I'm discussing this and breaking it down a little bit further. Blood antigens are just markers on our blood. So most of us are O negative, A positive. It's that negative and positive sign that are known as our RH signs. We usually inherit this from our parents. So as you can see in this image, the dad here is Rh positive and the mom is Rh negative. So the baby will then gain one of those positive or negative signs. The issue becomes whenever the mother is Rh negative and the baby is Rh positive. The fetal blood supply is separated from the maternal blood supply during pregnancy, but during birth, we do have a chance of these blood streams becoming mixed. This can actually trigger an immune response, and the mother's immune system can attack the fetal blood supply. This can lead to severe complications, such as hemolytic anemia. There is a test that can help detect this incompatibility, and it's called the Coombs test. If that test is positive, the mother will need to receive immunoglobulin at 28 weeks of gestation to avoid this type of complication. So let's discuss some of the risk factors. As we just discussed, that blood antigen incompatibility or positive Coombs test can be a risk factor for hyperbilirubinemia, as well as sources of excessive red blood cell breakdown. This includes any type of hemolytic disease, prematurity or being born at a gestational age of 35 to 36 weeks, A genetic predisposition or a sibling with the history of hyperbilirubinemia can increase the risk factor of that happening again with the second child. Or even that excessive bruising or that cephalohematoma that can occur during delivery. Remember, bruises cause an increased bilirubin level. And exclusive breastfeeding, which we discussed in the previous slides. So let's discuss some of the clinical features of hyperbilirubinemia. We'll of course see jaundice, or that yellow discoloration of the skin in the eyes, most specifically the sclera, or the white parts of your eyes. It's important to note that jaundice will progress and develop from head to toe, but once it starts to resolve, it will resolve from toe to head, and the head and eyes will be the last part to change back to their normal color. Hepatosplenomegaly will occur, and this is in some of those pathological causes of jaundice. And this is due to, again, remember the liver and the spleen are both involved in red blood cell breakdown and even conjugating this bilirubin. Edema can also occur in this pathological form of jaundice, and this is due to the high amount of hemolysis or red blood cell breakdown, so the body does try to absorb and keep that fluid. This is most common within the lower extremities. Decreased oral intake and decreased stooling. This can all lead to that increased amount of bilirubin within the bloodstream. It's important to note that if you see any of these clinical features, you need to intervene immediately because we can see some serious damage with these. Bilirubin encephalopathy can occur whenever we have an excess amount of bilirubin that builds up in the blood, and it can reach a toxic level. Some of the signs or clinical features with this will be lethargy or decreased activity, and this is more so than with just a sleepy newborn. Irritability or a high-pitched shrill cry. Remember, these types of cries are usually associated with neurological issues or complications. Poor feeding. Again, the baby's going to be a little bit more lethargic or sleepy, so they won't be eating as well or as often. Hypotonia, decreased tone in their muscles. They may seem almost more floppy or loose. And temperature instability. The newborn will not be able to regulate and maintain their own core temperature. If this goes untreated, this can actually lead to seizures and a coma. Whenever these bilirubin levels become toxic, remember they're starting to damage neurons, so we need to make sure we're intervening as soon as possible. One of the important differences between bilirubin encephalopathy and kernicterus is that bilirubin encephalopathy is temporary and reversible. Kernicterus, on the other hand, will lead to permanent chronic brain damage. Those neurons are being damaged and cannot be replaced once this bilirubin builds up to such a toxic level. We'll actually see a lot of the same signs and clinical features here, but I want to note some of the differences so you can tell these two issues apart. We'll still see the lethargy and decreased activity. We'll still see poor feeding and hypotonia. But one of the major differences is we'll see apnea. Typically, newborns or infants will stop breathing for about 20 seconds. This is just a pause in their normal breathing, and that's not concerning. But when it comes to apnea, this is where we see them taking longer pauses in between breaths, becoming hypoxic, or even changing color. We can also see an absent startle reflex, or that Moro reflex. Whenever you go to startle a newborn, unintentionally, you'll see them have this reflex where they reach their arms out and start to shake a little bit. This reflex is normal and part of the developmental process for a newborn, but it will be absent with kernicterus. These infants will also have that high-pitched shrill cry along with irritability. So let's discuss some of our nursing interventions and how we can treat this jaundice. Phototherapy is our number one intervention, and this is essentially a sunbath or tanning bed for these little babies. We'll put them under these phototherapy lights, as you can see in the image to the right. This will help break down that bilirubin and help them to actually excrete it through the stool faster, help the liver out a little bit. Some of the safety things that we need to implement when we're using these phototherapy lights is to make sure that we put little sunglasses or an eye shield over these infants. We want to decrease the risk and prevent any retinal damage. Make sure that you're closing the baby's eyes before you apply the eye shield. This is so we can prevent any type of corneal abrasion as well. Now with these phototherapy lights, they're fluorescent blue lights, and they'll actually monitor and regulate the baby's temperature. It's very warm under these lights, so we don't need to add any more blankets or clothing. We want to make sure we have as much skin exposed as possible to help break down that bilirubin, and also we need to avoid any burns or skin breakdown. So adding blankets or clothing can actually cause burns. Frequent temperature checks. Although the lights will keep the baby warm, we need to monitor to make sure they're not getting too hot or having any burns or dehydration. Turning the infant every 2 hours is extremely important to maintain skin integrity. Also, we need to make sure that we're having adequate and even skin exposure under these lights. Avoid lotions, as this increases the moisture content of the skin and can increase risk of skin breakdown. Increasing feedings can be very helpful as well. We want to avoid dehydration, so making sure they're hydrated by feeding regularly. And remember, more feedings, more stool, less bilirubin. Avoid supplements such as glucose water. We want to make sure that the baby is eating their breast milk or their formula. Monitor stool patterns. We need to make sure that they're stooling regularly, showing that they're excreting that bilirubin. And daily weights to assess for dehydration and adequate weight gain. Checking and monitoring regular bilirubin levels will help see the trend and will let us know whenever we can actually take the baby off these phototherapy lights. And ensure skin-to-skin contact. We need to allow the caregivers to take the baby out from under the lights and do skin-to-skin contact whenever they're feeding, so we can facilitate bonding.